Okay, this is Jacob Nelson for Bio461's Exam4 Essay2 questions. So we're going to get started. Explain all the membranes, pressures, and mechanisms that make negative pressure ventilation possible. And this is for the respiratory system, obviously. So we'll start with the membranes. The membranes of the lungs, the most inner membrane is the visceral pleura, right on the cover of the lungs. And then outside of that, you have the parietal pleura, technically covering the thoracic cavity on the inside. And so the space between the visceral pleura and the parietal pleura is the pleural cavity. It's a thin space. There's a little bit of, I believe it's water or fluids that fills in between that space. And so the different pressures we have going on is that in the pleural cavity, you have intrapleural pressure. It's normally negative at about, about 5 centimeters at rest. And there's elastic recoil that's pulling the lungs inward and the chest wall outwards, basically. Another type of pressure we have is alveolar pressure. It's usually equal to atmospheric pressure at rest, but can become more negative during inspiration when you're breathing in. And then we have a transpulmonary pressure. That's the difference between the alveolar and intrapleural pressure. And this is the purpose of that pressure. Transpulmonary pressure is supposed to help keep the alveolus open and keep it from trying to shrink up. And so the mechanism at which these happens, you start with inhale, right? The diaphragm contracts or pushes down. That allows an increase in thoracic volume. The intrapleural pressure, right? The pleural cavity space becomes more negative. This allows the alveolus to expand more, and the pressure drops below the atmospheric pressure, like I mentioned just before, as the air flows in. At which point the gas exchange will occur, and then normally you would exhale out that CO2 and start all over in reverse, I guess. Okay, that should cover that. Describe what a pneumothorax is and how it occurs. So by definition, a pneumothorax is when air, positive pressure maybe, air enters the pleural cavity, right? So normally that space in the middle is, sealed, but is when somehow it gets penetrated and that negative pressure that's supposed to be built in there goes away. It dissipates. And so this loses the pressure gradient in between the inside and the outside of the lungs, and can really cause the lung to collapse. And what it really looks like is it's shrinking up. The reason or what causes this to happen, it can be, very, very multiple different ways. I'm sure you can have a traumatic, wound. Let's say a knife penetrates the walls into your pleural cavity, allowing air to escape. Or maybe you break a rib and the rib punctures the lungs, causing also a pneumothorax. Sometimes a spontaneous rupture of the alveolus can occur to create a pneumothorax as well. It's more from an extreme physiological event. For the most part, that's typically the common causes of how a pneumothorax could occur. And obviously, it's not a good thing when it does happen. Okay, what is surfactant, and how does a lack of surfactant impair ventilation? Okay, so surfactant is a phospholipid with proteins that's inside of the lungs. It's made by alveolar cells. And it's supposed to, the function of the surfactant is supposed to help reduce the surface water tension from water, obviously, and that keeps it from making the alveolus shrink up or collapsing. So the surfactant is meant to make sure that the alveolus doesn't shrink too much because of surface tension, decreasing the pressure in the alveolus. But without surfactant, the alveoli can still collapse because of, well, I guess, yeah, like I mentioned, the water tension would decrease the partial pressure. And let's see, if that happens, compliance decreases, and then it'll be harder to breathe and can cause, issues after that. So, yeah, so that's that question. In this discussion, explain surface tension, the role of Laplace's law. Okay, yeah, so we need to talk about Laplace's law, what that is. So I mentioned surface tension, that is created by the water. It's kind of the force of that liquid that will kind of want to, I guess, close the space within wherever it's at, right? You see this in test tubes where it has like a U shape. That's also due to surface tension. But Laplace's law helps you to understand what's going on here. And Laplace's law is P equals 2T over R. P standing for pressure to keep the alveolus open. 2T, so 2 times T is surface tension, over R, which is radius, so the radius of the alveolus. So if the radius of the alveolus was small, if it decreased, it creates more pressure in the alveolus. Excuse me. But, in the opposite direction, if the radius of the alveolus were to get bigger or to increase, the pressure inside would decrease. So it has an inverse correlation. Yeah. And then with surface tension, if surface tension increases, then so does the pressure of the alveolus. But if surface tension decreases, so will the partial pressure of the, it's not partial pressure, just pressure of the alveolus will also decrease. So that is a, what is it called? Proportional relationship. Let me see if I got that. Yeah, so the smaller alveoli needs more pressure to stay open, and so the bigger alveolar requires less pressure to stay open. And then surfactant will try to lower the surface tension, but the surface tension, if it increases, if there's a lot of it, that also increases pressure that required. And so, you just kind of like want a good balance between all those different things. So that is Laplace's law. Next question is, explain the alveolar gas equation and how it can be useful clinically. Okay, so let me try to find it here in my notes. Okay, so the alveolar gas equation, it's kind of long, so I'll just try to say what it is first. It is the partial pressure of oxygen in the alveolus equaling to the fraction of inspired oxygen times barometric pressure minus water vapor pressure minus let's see, partial pressure of carbon dioxide in the arterial over the respiratory quotient. And the respiratory quotient is a value, I think we typically say it's around 0.8. And so that's the alveolar gas equation. There's many different parts to it, but the overall reason why we would need this equation is to help us estimate the how much oxygen is in the alveolus, how much oxygen can be in the blood, and so what kind of exchanges, if a expected amount of gas exchange is occurring, and what kind of gradient there is there between the alveolus to the blood. And this equation will help us to probably calculate, with some exceptions, I'm sure, what we are seeing in a patient. So let me make sure I answer that question all the way. Yeah. Discuss how CO2 and O2 are transported in a blood. Include a description of the oxygen hemoglobin dissociation curve, blah, blah, blah. All right, let's just start with CO2, O2, how it moves. So when the gas exchange occurs from the alveolus to the blood, red blood cells, inside of them has a protein called hemoglobin. And hemoglobin is able to take in that oxygen, and it will bind the oxygen to it and carry it all the way around the whole body. And I believe it's somewhere about, one hemoglobin can hold 250 million atoms of oxygen, I believe. And I think that's typically around 4. Or maybe this was just the example Brother Hunt showed, but hemoglobin carries a lot of oxygen. But so for the oxygen that's traveling past through the gas exchange, about 98% or so should be bound to the hemoglobin in red blood cells. And then the other 2% is just dissolved in the plasma, just hanging out until it gets picked up. Carbon dioxide, on the other hand, when it wants to, right before it exchanges out into the alveolus to get breathed out, it's known to be in 3 different forms. About 70%, so most of the carbon dioxide is from bicarbonate, and that occurs from a equilibrium equation, that we know of. It's the carbon dioxide plus water equals to bicarbonate with a proton hydrogen atom. So this kind of exchange occurs, and this bicarbonate that's in the blood, I guess, will get released, and we need carbonic anhydrase, the enzyme, to allow this this conversion, I guess, if you will, to occur. But only 20% of so that was 70%. 20% of carbon dioxide that we find is bound to the hemoglobin. It's when the hemoglobin delivers oxygen to cells or to tissues, it exchanges it with carbon dioxide and takes on that carbon dioxide, and it binds it to the hemoglobin itself. So I guess that's called a carbaminohemoglobin. Weird word. And then the rest of the 10% of carbon dioxide is just found and dissolved in the plasma, just like how 2% of oxygen is found to be dissolved in the plasma. So that's basically how oxygen and carbon dioxide is transported around in the blood. And we want to talk about the oxygen hemoglobin dissociation curve and what factors kind of influence the affinity of hemoglobin for oxygen. So this dissociation curve kind of looks like an S, right? you have, I believe it's partial pressure over the amount of oxygen. Let's see. Maybe I should just show the picture. It might be easier, but so at high levels of partial pressure of oxygen, hemoglobin is super saturated with oxygen in it. That's more in the high points, but once it starts to make that decline, there's a little threshold where it is harder to keep the oxygen saturation up. And so we usually see this being measured with the pulse oximeters, those little clips that go on your finger, and it gives you usually a percentage. Anything above 95%, I believe, is what a normal range should be. But if these people or patients who are experiencing if they're becoming hypoxic, you notice that their saturation levels are very low, like below, they could be in the 80s, and really poorly if it's below 75%, that's really bad as well. So things to consider with this curve diagram is that there are shifts that can change the curve, shifting it to the right or to the left. And so if it shifts to the right, it has a decreased affinity for, there's a decrease in affinity where more oxygen is released. And if there's a left shift, there's an increased affinity and less O2 is released. So with the right shift, you have an increase in carbon dioxide, increase in acid, increased temperature, and there's a molecule that is at play here called BPG, and it's a 3-carbon chain molecule that has phosphorus bound to the second and third atom, or second and third carbon. For whatever reason, I don't remember right now. This can affect this curve, this shift. So if there's increase in that 2,3-BPG, it causes a right shift. But if there's a decrease in 2,3-BPG, it causes a left shift. Yes. Let's see if I need to explain anything else. How do these factors affect oxygen hemoglobin dissociation curve? Yeah, I guess maybe I already mentioned it, but a left shift, like I mentioned, is a higher affinity and less oxygen is released. So there's decrease in CO2, decrease in acid, so it's more alkalosis, decrease in temperature, decrease in the 2,3-BPG. So right shift, I guess hemoglobin dissociation curve can actually help the tissues get more oxygen, especially when you're exercising. And so, it's kind of like a clinical example of what it looks like, I guess. Let's see if I'm missing anything else. No, I think that's everything. Okay. Thank you for listening to this video. I'll see you next time.